Hello there. So we were studying epidemiology, so let's continue further. So now here we have a question. A new drug called prostagist is undergoing clinical trials for the prevention of prostate cancer. The trial looks at the incidence of prostate cancer within a 5-year period. Certain data is given in the form of table. Uh, Drug is compared with placebo, number of patients who develop prostate cancer within 5-year period by the drug, and number of patients who did not develop prostate cancer within the 5-year period is given. Now we have to calculate the relative risk reduction here. So as we know, relative risk reduction is calculated when we know about the absolute risk, because first we have to calculate absolute risk of the control group, and then we have to calculate absolute risk of the treatment group. Then we have to calculate absolute risk reduction divided by absolute risk of the control group. That will give us relative risk reduction. So absolute reduction of control group would be uh, the one which is being given placebo. So it will be 10 upon 100, and for prostagist, or that is the drug or the treatment group, absolute risk would be 4 upon 100. The number of cases which are affected by the disease or affected by the event divided by total number of people in the group, that is the absolute risk. So 10 upon 100 minus 4 upon 100. So 4 upon 100 is 1 by 25. 10 upon 100 is 1 by 10. So 1 by 10 minus 1 by 25, that is zero point 0.1 divide minus point okay, yes, that is right, 96. So we will subtract, and then so zero point 0.1 minus 0.04, that will be 0.06, and now we have to divide it by 0.1 and multiply it by 100, because we have to calculate in terms of percentage. So relative risk reduction here, so 0.1 minus 0.04 will give us 0.6. So 0.6, if we convert it into percentage, that will be 60%, because we have to multiply it by 100. That will give us 60%. So that will be and yes, we have to divide it by absolute risk of the control group, that was 0.1. Okay, so relative risk reduction tells us how much the new treatment had reduced the risk of developing the disease relative to the control group. Relative to the control group is important here, and this is much more difficult question as compared to most of the other calculations group. First we have to calculate absolute risk of the control group, absolute risk of the events in the control group. So then absolute risk of the treatment group. To calculate the relative risk reduction, it will be equal to absolute risk reduction upon absolute risk of the control group. So this means there is a 60% reduction in the relative risk of prostate cancer in the treatment group compared with the control group. So, relative risk tells us about how much the new treatment has reduced the risk of developing the disease as compared or in relation to the control group. So, it is 60%. There is 60% reduction in the relative risk of prostate cancer in the treatment group as compared to the control group. That is what it means. Okay, so I think we have already studied earlier about everything about risk reduction. We don't have to go through that again. Anyway, let's move ahead. Now, in this question, there is a clinical trial which was performed looking at a new drug. It is thought that this new drug is able to modify cardiovascular risk factors and reduce the risk of myocardial infarction. 200 patients were randomized into two separate groups. One group received the new drug while the other group received the placebo. Participants were then followed up for 10 years. So results are given. So they're asking the number needed to treat for this new drug to prevent one myocardial infarction. As we know, the number needed to treat, the formula is number needed to treat is equals to 1 upon absolute risk reduction. Number needed to treat is actually the total number of patients, average number of patients which are to be treated so as to prevent one bad outcome. And number needed to treat, that is NNT, is equal to 1 upon absolute risk reduction. So we have to simply calculate first absolute risk reduction. So for that, control and treatment. So absolute risk of the control group, that is placebo group, is 20 upon 100. And for the new drug, it will be 16 upon 100. So we will subtract it, and then we will get the absolute risk reduction, and then we have to reciprocate it, or we have to calculate the reciprocal 1 upon whatever absolute risk reduction is. So 20 upon 100 minus 16 upon 100. So that will be around 1 by 5 minus 4 by 25. 1 by 5 minus 4 by 25. So number needed to treat is calculated by 1 divided by absolute risk reduction is equal to 1 upon ARR. The absolute risk reduction here is the absolute risk in the control group subtracted by absolute risk in the treatment group. That is 20 by 100 minus 16 by 100. So that is 0.2 minus 0.16. That will be 0.04. 1 upon 0.04 will be around 25. It will be 25. So it can be interpreted that 1% would benefit by not developing myocardial infarction for every 25 people receiving this new drug over a period of 10 years. So that is what it means. 25 people. The drug needs to be given to 25 people for preventing one person from getting myocardial infarction, or one person would benefit by not developing MI for every 25 people receiving this drug over 10 years. That is number needed to treat. Okay, so we have already studied about this. Let's go ahead. Now 10,000 women underwent a newly developed cervical smear screen. Thousands of them had a smear result which shows pre-malignant changes and had further investigations and biopsies. Only 100 women who had undergone biopsies had pre-malignant changes seen on histology. What is the single best term to describe the cervical smear test? So they are asking what is the single best term. Now, out of 10,000 women, 1,000 of them had a smear result which shows pre-malignant changes and had further investigations and biopsies. 100 out of 1,000 were actually positive, were actually having the disease. 100 out of 1,000. So, these cases were actually true positive. So 900 were actually those who tested positive but did not have the disease. So they were false positive. So we are having high false positive rate here. So now false positive. So we are here talking about low specificity because it is having high false positives. So we are talking about low specificity of the test. That is what it means. So we just quickly write certain important statements. I think these we have already written before. That is high sensitivity. We are talking just in terms of false cases, by the way. Now, as we know, sensitivity actually in its formula has true positive cases in the numerator. But here we are talking about negatives. So high sensitivity means low false negative. Low sensitivity means high false negatives. It's obvious. And specificity in its formula has true negative cases in the numerator. So high specificity will mean few false positive, low false positive, and low specificity will mean high false positive. So it is the other way. It is the other way round uh, as compared to the formula. Here, in terms of sensitivity, we will see false negatives and which are high, and in terms of specificity, we will see false positives. But in formula, it is true positive in the sensitivity and specificity true negatives. Okay, now let's move on to the sensitivity, specificity, positive predictive value, negative predictive value, accuracy, and odds ratio. Sensitivity was true positive cases divided by total number of cases which were actually having the disease. That is true positive plus false negative. And specificity was for true negative cases divided by number of cases which were actually not having the disease. That is true negative plus false positive. True negative plus false positive. Positive predictive value was true positive divided by true positive plus false positive. Negative predictive value was true negative divided by true negative plus false negative. Accuracy is true positive plus true negative divided by total number of cases, A plus B plus C plus D. Odds ratio is true positive into true negative divided by false positive into false negative. That is odds ratio. AD upon BC. And accuracy is true positive plus false positive divided by A plus B plus C plus D. Okay, let's move ahead. Now, in this question, a new point of care screening test is being developed to identify a protein called ROVR, which is used to determine patients who are infected with a new strain of coronavirus. The test is performed on respiratory samples obtained by a nasopharyngeal swab. Following the testing, PCR is used as a gold standard to confirm the presence or absence of the new strain. The initial studies have revealed the following results. So, again, a table has been given. A number of cases who had the new strain of coronavirus confirmed by PCR, and number of patients who did not have the new strain of coronavirus confirmed by PCR is given. So here we have to calculate the correct value which represents the accuracy of the new screening test. Now we know accuracy is equal to true positive plus true negative divided by total number of cases. So here true positive would be the cases which have been which are positive in both, like actually positive having the disease and even the test is positive, so that is 20 here. Plus we have to see the true negative cases, that will be negative in both, not having the disease, the test is negative. 20 plus 80, that is 100, divided by total number of cases, that is A plus B plus C plus D, that is 200 here. So 100 divided by 200, that is 1 by 2. And actually the total is 300, not 200, because that is 20 plus 80 plus 100 plus 100. So 100 divided by 300, that is 1 by 3, so it would be 33.3%. So the overall accuracy of a clinical test, let's see the definition here. Overall accuracy of a clinical test is a proportion of all tested persons who are correctly identified by the test. This is calculated by taking the proportion of all the test results, positives and negatives, which are correctly identified as having the new strain of coronavirus. So it is the proportion of all tested persons who are correctly identified. So it is the proportion of all tested persons who are correctly identified by the test. And accuracy equal to A plus D on A plus B plus C plus D, that is true positive plus true negative. So the people or the number of persons who are correctly identified by the test, that is the proportion of all the tested persons who are correctly identified. For proportion we have to take a denominator as well, which is here total number of persons. So this test, as it is having 33.3 accuracy, so it has poor accuracy. So if the test was used, infected patients would be given all clear and sent back to the community, which would spread the virus even further. So, as they say, one thing worse than no test is a bad test, because bad test will lead to actually mixing up of infected individuals with the community, which is otherwise healthy. So, yes, one thing worse than no test is a bad test. Anyway, let's move further now to the next question. So, here each year 9,50,000 people develop MI in a population of, okay, in a population of 250 million people, and out of these 2,15,000 die and 1,12,500 die in the first hour. Which of the following is the single most likely value for the incidence? So now we are, so here we have to focus on the incidence. As definition of incidence says, as definition of incidence says, it is a measure of the probability of occurrence of a given medical condition in a population within a specific period of time. Or it is simply the number of new cases of a disease occurring within a population during a specific time. Incidence clearly tells us about the number of new cases of a disease occurring within a community or a population during a specific time. So in this question, 9,50,000 people. These are the new cases each year which are developing MI within a population during this 1 year time. So that will, I think that will give us incidence. So yes, there is no need of any calculation. We just have to know the definition that incidence is the total number of new cases occurring in a community, in a population within a specific period of time. That is incidence. Okay, let's move further. Now in this question, 178 women with hypertrophic cardiomyopathy were recruited in a study. Half of these women were given drug A, other half were given drug B. After this, they were followed up every 3 months from 2010 to 20 to evaluate their condition. So, what is the single most likely type of study which is occurring? Clinical study. So, here we are already starting with the outcome. We are already starting with the disease, and then we are evaluating their condition. So, we already know the outcome that these are the women with hypertrophic cardiomyopathy, and we are simply giving half of them a certain drug and the other half another drug, and they are being followed. So it is not case control, and it is not a retrospective study either, and it is a control trial most possibly. So control trials, they tend to introduce a treatment. Control trials are usually used for new drugs. Control trials tend to introduce a treatment. In this case, drug A is compared with drug B. Both groups are followed in time and their outcomes are recorded. This can either be a randomized control trial where people are allocated different interventions randomly, or a non randomized control trial where people are allocated different interventions using a method which is not random. So, the distractor here is a prospective cohort study. Prospective cohort study are observational. They are not uh, they are not altered by the researchers. So, but here alteration is there. We are giving the drug, so we are altering the outcome. Prospective cohort studies are observational. This means that researchers would not interfere by giving drugs. They would only observe the risk factors of the two groups, look at the outcome. In other words, they recruit participants before any intervention and follow them into the future. So, takeaway point here is something about control trials. They tend to introduce a treatment. Example, drugs are compared A and B, and both groups are followed in time and outcomes are recorded. Now, be a this can be a randomized control trial, or it can be a non-randomized control trial. So, what is the difference here? In randomized control trial, people are allocated different interventions randomly. People allocated interventions randomly. In non-randomized control trial, people are allocated different interventions using a method which is not random. People allocated interventions using a method which is not random. So this is the difference here. Now we'll move on to the next question. In a study to detect the efficacy of a new screening method to detect breast cancer, a new imaging technique called Shenatium technetium scan technetium scan was tested on 1,000 women. 200 of those who were scanned came back with features suggestive of malignancy. Upon further tissue biopsy, 170 of them were confirmed to be malignant. Only 20 of those who came back negative using the scan develop cancer later. What is the positive predictive value? Now we know that positive predictive value is equal to true positive cases upon total positive cases, true positive plus false positive. So here true positive cases are like test is positive and they are also having the disease. So 200 of those who were scanned came back with features suggestive of malignancy. So 170 of them were confirmed to be malignant. So here 170 are actually true positive because their test was positive and they also were confirmed to be malignant. So these are true positives. So 170 divided by 170 plus, and what are the false positive cases? False positive, that means they are testing positive but they are actually not having the disease. That is only 20 out of those who came back negative using the scan developed cancer later. So they were actually uh, having the disease but they came back negative. So these are false negative actually. False positive would be those 30 cases. 20, only 20 out of those who came back negative using the scan developed cancer later. So who developed disease and they tested negative. These are false negative. So we are not concerned about false negative here. So 30 of them were confirmed to be non-malignant actually. 30 of them confirmed to be non-malignant. And out of those 30, 20 were those. So 10 were those who actually tested let me just calculate it a little. So here what we have to see is true positive cases are 170, that's right. Now we have to divide it by true positive plus false positive. So true positive cases here are 170, right? And false positive would be 30 out of, because out of 200 170 of them were confirmed to be malignant. So other 30 were actually non-malignant, but they tested positive. So they were false positive because they were not having the disease. They were false positive. So 170 divided by 170 plus 30, that is 170 upon 200. So that will be, and then we have, because the options are given in percent, so we have to multiply it by 100. Positive predictive value to get the positive predictive value, so it would be around 85%. In this case here, 170 out of 200 who had positive features using the new scan were confirmed to be malignant. Higher the value, the more sensitive the test is to detect the disease. That's right, more will be the true positive cases, more will be the sensitivity of the test, because less will be the false positive cases, and less and more will be the sensitivity. So positive predictive value can be described: if a subject has an abnormal screening test, what is the probability that the subject really has a disease? If a subject has an abnormal screening test, that is a positive screening test, what is the probability that the subject really has a disease? The formula is the number of true positives open divided by total positives. So positive predictive value is basically the proportion of positives which are true positives. So that test, a new screening test can give a lot of positive results. So out of them, which are true positive, that proportion is actually positive predictive value. And to calculate it in percentage, we have to multiply it by 100. That is very important because there can be certain options to confuse. Anyway, let's move ahead. A study was done to determine the efficacy of a new screening method to detect cervical cancer compared to the current conventional method. The results of the study show a p-value of 0.4. So which of the following is true? So we studied p-value that if p-value is more than 0.1, then the test is statistically insignificant. If it is less than 0.05, then the test is statistically significant. If it is less than 0.01, uh, then there is a very strong evidence. So now clearly it is mentioned here p-value is 0.4, which is more than 0.1. So it is statistically insignificant. So the option which would be correct will be the new screening method is not effective as the p-value is not significant, because p-value is 0.4, that is more than 0.1. This we have to remember. If p-value is more than 0.1, statistically insignificant, less than 0.05, it is statistically significant. If it is less than 0.01, then it is having a very strong evidence. Let's let's write certain things about the p-value. A p-value is a probability calculated after running a specific statistical test on data collected. Smaller the p-value, less likely the observed results are unusual or just happened by chance. P-value is a probability calculated after running a specific statistical test on data collected. Smaller the p-value, less chances that the observed results are unusual. So more will be the p-value, there are more chances that the observed results are unusual. So it is good that the p-value should be less. because if the p-values are less, then there are more chances that the observed results are usual. So smaller the p-value, less are the chances that the observed results are unusual. So more are the chances that they are usual, obviously. Or it just happened by chance. So smaller, it should be smaller. The p-value should be smaller. Smaller the p-value, less are the chances that the observed results are unusual or just happened by chance. It is used to determine if the outcome of a study or an experiment is statistically significant. The p-value is used to determine if the outcome of a study or an experiment. P-value is used to determine if the outcome of a study or an experiment is statistically significant. It is a way of telling if the results obtained from the experiment should be taken seriously or not. Way to tell, way to know if the results obtained from the experiment should be taken seriously or not. As there is low likelihood that this outcome just happened by chance or unusual or was the result of luck. If if the p-value is low, so low p-value means that null hypothesis is true and there is low chances that outcome is a result of luck. Or it is unusual. So most researchers refer to statistically significant as p less than 0.05, statistically highly significant as p less than 0.001. P less than 0.001 statistically highly significant. So experimental studies that have a p-value of less than 0.05 are considered good enough with the assumption that luck had little to do with the results. In other words, there is less than 5% chance that these results were just by chance or a coincidence. Or so there are no questions to which require us to calculate the p-value for the exams. It is usually automatically calculated by a statistical program. So here the p-value was zero point 0.4, which is quite high, more than zero point 0.1, so statistically insignificant. Higher p-values indicate that evidence is not strong enough to suggest that an effect exists. Okay, so basically what we have to remember from here is, if p-value is more than 0 0.1, then the data or outcome is the test itself is statistically insignificant. Uh, Statistically insignificant, and there are more chances that the outcome just happened by chance, by coincidence, by luck. And if p-value is less than 0.05, then the test new screening method is statistically more significant, the data is more statistically significant. And if p-value is less than 0.01, then there is a very strong evidence. If p-value is less than 0.001, then it is having even higher statistical significance, like it is statistically highly significant if p-value is less than 0.001. And if p-value is lower, then null hypothesis is true. And if p-value is higher than 0.1, then the null hypothesis is false. If it is less than 0.05, then null hypothesis is true. Okay, let's move further. Two groups of women with osteoporosis were recruited to be involved in a study. They were divided using allocation software into separate groups. One group of women were given drug A, the other group of women were given a placebo. Both groups of women were then followed up at frequent intervals for the progression of osteoporosis for the next 10 years. What is the single most likely type of clinical study in this scenario? As we can clearly see here, an allocation software is used to separate them into two groups, and we were already knowing that both the groups were having the outcome, that is the disease, osteoporosis is there. uh, One group is given one drug, other group is given a placebo, so it is not a case control study. And because we are giving drugs, so it can't be an observational study, so it can't be a cohort study, prospective or retrospective, any of that. So it is either a randomized control trial, which is having more chances, or it can be cross section, but that is also observational. So it is a randomized control trial more likely. Yes, it is actually randomized control trial. Randomized control trials tend to introduce a treatment, in this case drug A, which is compared with a placebo in another group. Both the groups are followed in time, outcomes are recorded. Distractor here is a prospective cohort study. Prospective cohort studies are observational. This means that the researchers would not interfere by giving drugs. They would only observe the risk factors of the two groups and look at the outcome. Okay. Let's see a little bit about cross-sectional study here, because we were thinking on that line as well. This is a study which describes the relationship between disease and other factors at one point of time in a defined population. These are often used for comparing the diagnostic tests. Okay, it is a study which describes the relationship between disease and other factors at one point of time in a defined population. These are used for comparing diagnostic tests. A good example would be researchers performing a survey in a population to determine the relationship between increased level of serum cholesterol and echocardiographic evidence. Both the exposure and the disease outcome, both the exposure to the risk factor and the disease outcome are taken at the same point of time. It is like a snapshot of a population at a specific time. That is cross section. Okay, fine, that's clear now. Cohort study as well as case control study both are observational, by the way. Only randomized control trial is one where there is actual intervention, or researchers can alter, they intervene, alter the outcomes, and methods such as randomization and blinding are done. These are experiments which introduce a treatment or exposure to study its effect on the real patients. Okay, let's go further now. A group of patients with atherosclerosis are followed forward over a period of time to investigate the outcome according to exposure to different factors. It started with two groups free of disease and followed forward for a period of time. What is the single most likely study design? Okay, so here first we already know about the group of patients who are having atherosclerosis, and they are followed forward over a period of time. But it started when they were free of disease. Most likely, it seems to be a case of uh, prospective cohort study. Now, as we know, case control is always retrospective, but cohort study can be prospective and retrospective. Now, a prospective cohort study assembles the participants and follows them into the future. Cohort studies are observational, they evaluate the natural history of a condition. Patients are divided into specific groups based on their exposure characteristics and followed up over a period of time to determine if the outcome or the disease of interest, if the outcome or disease of interest develops. The distractor here is a case control study. Case control studies are retrospective. They look at two groups at the start, one with the outcome or the disease, one without the outcome or disease. They look retrospectively back in the past to assess if there was significant difference in the rates of exposure to a defined risk factor between the groups. So there in case control study, we already have two groups, one with the disease, another without the disease, case and control. And we look retrospectively back in the past to assess if there was difference in the rate of exposure to defined risk factors. So that is case control, always retrospective, whereas cohort can be prospective and retrospective, but it always flows forward. And here also we are directly going forward, and it is prospective only. Started with two groups of disease, two groups who are free of disease, and then followed forward for a period of time. So it is prospective. They are followed forward over a period of time to investigate the outcome according to the exposure to different factors. Let's read a little about case control study here. In case control study, patients who already have a specified condition are compared with people who do not have that particular condition. Study designs are observational, meaning that researchers study but do not alter what occurs. They look retrospectively back in the past to assess if there was difference in the rate of exposure to a defined risk factor between the groups. Okay, so we look back at the history. Uh, that is case control. Okay, cohort. In cohort study, these studies identify a group of people who share a defining characteristic. Group is then compared with a similar group of people with the same defining characteristic. These are purely observational. They may be prospective, going forward in time, retrospective, happened in the past. Because these studies are observational, researchers do not intervene. Prospective can be group A who smoke, group B who do not smoke, followed in time to determine who develops lung cancer. Now, difference between a case control and a retrospective cohort study. A case control, in case control, one starts with the outcomes and studies the exposure. In retrospective cohort studies, one already has determined the exposure, but now needs to study the association of exposure to disease outcome. So in case control, we know about the outcome. We start with the outcome, study the exposure, as we know, one with the disease, one without the disease. In retrospective cohort study, one already has determined the exposure. In retrospective, we start with the exposure. We already know about the exposure. Now we have to study about the association of exposure to disease outcome. In simple terms, case control studies start with patients in two groups, disease and not disease, then look back in time to determine who was exposed to the risk factor. Retrospective cohort study looks into the past, take two groups, exposed and not exposed. We know about their exposure. We look back in the past, but still we uh, know about their exposure. We start from the exposure, take two groups, exposed and not exposed, and we look into the present to determine who has the disease. Okay, I hope it's clear. I think it's quite clear now. The difference. This is important. And okay, so now in this question, 1000 patients are evaluated for pre-malignant and malignant oral lesions by fluorescent light. A total of 200 of them had abnormal lesions which required biopsy, which was considered the gold standard for detection of lesions histology. 20 of the remaining 800 patients who initially did not show any abnormal lesions using fluorescent light developed oral cancer, which was confirmed by biopsy within 2 months. Of all the biopsies who had abnormal lesions seen on fluorescent light, 50 patient results showed pre-malignant or malignant changes. Which term accurately describes the 20 patients who developed oral cancer without any abnormal lesions seen on fluorescent light? So obviously these are the patients who developed oral cancer, had the disease without any abnormal lesions seen on but on the screening negative. So these are false negative. False negative is where the test incorrectly indicates the absence of the condition, in this case pre-malignant and malignant oral lesion. These patients initially tested negative under the fluorescent light but later found to be positive in the biopsy results. This is termed as false negative. They are actually positive, having the disease. Now, the next question. This is the likelihood of a test reporting positive when the condition being tested is actually present. What is the single most likely term? Likelihood of a test reporting positive when the condition being tested is actually present. So here we are talking about sensitivity. Sensitivity is a measure of test's ability to correct to correctly detect people with the disease. It is a proportion of disease cases that are correctly identified by the test. Let's let's write the definition of this. It is a measure of a test's ability to correctly detect people with the disease. It is the proportion of diseased cases that are correctly identified by the test. Correctly identified by the test. So we already know the formula, but we can also write it in a different way. Sensitivity equal to of number with disease who have a positive test, that is true positive cases. Number with disease who have positive test divided by number with disease. Now with disease, first sensitivity is true positive cases divided by true positive plus false negative. That is all the true positive cases divided by total number of cases which are actually having the disease. So actually having the disease will include true positive cases as well as false negative, because they are actually positive. They are actually having the disease, but they are just falsely coming out negative. So it will include true positive cases divided by true positive plus false negative. Okay, let's move further. Now, in this question, a total of 5,000 women are studied to evaluate pre-malignant and malignant cervical lesions by smear. All 5,000 women were screened for cervical cancer using a smear test. 1,000 of these women had an abnormal smear. All 1,000 women who had an abnormal smear underwent colposcopy and biopsy. Of those who went for biopsy, 20 of them had a histology that showed pre-malignant changes. Which term accurately described the 20 women? So these 20 women, so of those who went for biopsy, so 20 of them had a histology that showed pre-malignant changes. Okay, so 5,000 were screened, 1,000 of them were having an abnormal smear. So all 1,000 women who had an abnormal smear, they were testing positive under the screening test. They underwent biopsy then. So out of these 1,000, only 20 actually showed pre-malignant changes in the biopsy, histology, or colposcopy. So 20 were tested positive by the test, as well as they were also tested, they were actually having the disease. So these are true positive cases. True positive is where the test correctly indicates the presence of the condition. 20 patients who initially had an abnormal cervical smear were found to have a positive biopsy result. This is termed as true positive. So those who suffered from malignant changes were not mentioned, but would have also been included in the number of true positives. Pre-malignant or malignant. Here malignant were not mentioned. So okay, so the cases which are uh, shown positive by the screening test and are actually having the disease. So these are also confirmed by the gold standard tests like biopsy, histology, and colposcopy, and all those tests. So both of them are positive. Those are true positive cases. So let's move further. A new test called Lima has been developed to identify pancreatic cancer. In the study, 50 patients with a positive Lima had confirmed pancreatic cancer on biopsy. Okay, 20 patients with a negative Lima had confirmed pancreatic cancer on biopsy. 500 patients with a negative Lima had biopsy that excluded. 5 patients with a positive Lima had a biopsy that excluded pancreatic cancer. Okay, what is a positive predictive value? So we know positive predictive value is equal to true positive cases divided by total number of positive cases, that is true positive plus false positive. So true positive are 50 patients with positive had confirmed pancreatic cancer. These are true positive, that is 50 divided by 50 plus we have to calculate the false positive cases. False positive are those who are coming out positive in the test but actually not having the disease. So 5 patients with a positive Lima had a biopsy that excluded pancreatic cancer. So they are not having the disease, but the test is coming out positive. So these are false positive. These are 5. So 50 divided by 50 plus 5 into 100. Or 50, if they are not asking percentage, then just 50 divided by 50 plus 5, that is 50 upon 55. That is how we'll calculate it. The positive predictive value looks at the probability that a person who has a positive test really has the disease. You would take the people who have tested positive. You would take the people who have tested positive, who have the disease, divided by the total number of people, total amount of people with a positive test. Total amount of positive tests that had confirmed pancreatic cancer 50. Total amount of positive tests 55. Positive. Okay, so this we can write. Here we can write that positive predictive value set the probability that a person who has a positive test really has the disease. Okay. Okay, so let's move ahead now. A study examines the effects of smoking in 200 people aged 50 years and above for a period of 5 years. 100 of them were smokers and the other 100 were non smokers. In the period of 5 years follow up, 6 people from the smoking group developed chronic obstructive pulmonary disease and 2 people from the non smoking group developed COPD. What is the relative risk of developing COPD in the smoking group? So they are asking relative risk of developing COPD in the smoking group. Now we know risk is equal to the total number of cases which have developed the disease or which have developed the event divided by total number of people in that group. So in the smoking group, they are asking in the smoking group how many people have developed the disease. 6 people from the smoking group have developed COPD. So 6 divided by total number of people in the smoking group. There were 100 smokers. So 6 divided by 100, that will be 0.06. But we have to focus here because they are not asking absolute risk of the group, they are asking relative risk. So for relative risk we have to divide it by the absolute risk of the control group, that is absolute risk of the non-smoking group. So absolute risk of the non-smoking group will be 2 people develop COPD, so 2 divided by 100, that is 0.02. So 0.06 divided by 0.02, that will be 3. So in other words, smoking increases the risk of COPD by 3 folds or 3 times. That is the relative risk. In the people who are smoking, according to this study, the risk is 3 times more in relation to the people who are not smoking. So we have to focus here that if relative is asked, the important point here is two important things actually. One is that if relative is asked, then we have to consider risk of control group in denominator. If relative risk is asked, then we have to put risk of control group in the denominator. Second thing is, if percentage is being asked, then we have to take care of multiplying things by 100. These are 2 points to remember here. This one is from earlier actually. Anyway, so that's how we'll calculate relative risk. Absolute risk divided by absolute risk of the treatment group or the group of interest divided by the absolute risk of the control group. That will give us relative risk. Here we are not calculating reduction. Relative risk is equal to absolute risk of the treatment group divided by absolute risk of the control group. Absolute risk of treatment and control, we know how to calculate them. Absolute risk reduction is absolute risk of the control minus absolute risk of the treatment. Now and number to treat uh, is equal to 1 upon of absolute risk reduction. Number to treat is equal to 1 upon absolute risk reduction. Relative risk reduction, absolute risk reduction upon absolute risk of the control group. Odds ratio AD upon BC we know. True positive into true negative divided by false positive into false negative. Odds ratio. Okay. Okay, so let's move ahead. Here there is a case control study which looks at the risk of strokes in 145 men where some of them were smokers, and results are given. Smokers and non-smokers who developed stroke and who did not develop stroke. So we have to calculate odds ratio of developing stroke in men who smoke. What is the odds ratio of developing stroke in men who smoke? So odds ratio, as we already know, AD upon BC, or uh, they were smoking as well as they developed stroke. So 30 into 50 upon 25 into 40. That will be around 1500 divided by 1000. 15 by 10, that is 1.5. So let's remind ourselves of the odds ratio formula, which is AD by BC. That is, we have to just remember that AD by BC, odds ratio. So crisscross we have to multiply and put them in a proportion. That will give us odds ratio. By the table you can go true positive into true negative divided by false positive into false negative. This can be interpreted as individuals with strokes are 1.5 times more likely to be exposed to smoking than those without strokes. Individuals with strokes are 1.5 times more likely to be exposed to smoking than those without strokes. Okay. So for odds ratio, let's go into a little detail about odds ratio. It is defined as a probability an event will occur over the probability that it will not. It is defined as a probability that an event will occur over the probability. It is a ratio of that it will not occur. It is a ratio of success over losses. Now, in a game of football, if Chelsea plays with Liverpool 5 times, wins 1 out of 5, the chances that Chelsea will win the next match is 20%. The odds of winning, however, is not 20%. This is because the odds of winning is not 20%. This is because the odds ratio is calculated on the probability that Chelsea will win Liverpool versus Liverpool will win Chelsea. That is 20 by 80%. That is 1 by 4. So if you were to make a bet on Chelsea winning with a betting company, for every £1 you put in, you will win £4 if Chelsea wins. So if we will put it on the table, then odds ratio as we studied earlier. equal to AD upon BC. For example, a case control study looking at the risk of venous thromboembolism in postmenopausal women using HRT. Now, who did not develop HRT and no HRT. So a table is given and we have to remember the formula of odds ratio AD upon BC, crisscross AD upon BC. So yes, this can be interpreted as individuals. It came out to be 2, so it can be interpreted that individuals with venous thromboembolism are 2 times more likely to be exposed to HRT than those without venous thromboembolism. Do not interpret it the other way around. Individuals with HRT are 2 times more likely to develop venous thromboembolism. That would be incorrect since this is a case control study which begins with the outcome and then looks at exposure. Yes. As we know, in case control study, we already know the outcome. So the case control study begins with the outcome, and then we look at the exposure. So we cannot comment on developing the outcome here, developing the disease here. We can comment whether they were exposed to the risk or not. But we have to keep in mind that we can't comment on the disease because we have to consider that we already know about the outcome, already know about the disease. We are just trying to know about the exposure now. So the individuals with venous thromboembolism are 2 times more likely to be exposed to HRT than those without venous thromboembolism. We are not commenting anything on whether or not they are developing disease, any of the group. Okay. Okay, so now let us move ahead. So now a total of 50 people were on board on an aircraft traveling to London from Rome. A week later, 5 passengers who were British nationals developed flu-like symptoms were all tested positive for the new ABLE77 virus. ABLE77 is a new virus which has not previously been seen in the UK. One incubation period later, 10 household members of the ABLE77 positive passenger also tested positive for the same virus. If the total number of household members of the 5 passengers is 25, inclusive of the 5 passengers, what is the secondary attack rate among household contacts? So 5 people have spread it to another 20 people. And they're asking about secondary attack rate. So we have to study about the secondary attack rate here. Secondary attack rate. secondary attack rate is equal to number of secondary cases divided by number of persons in the group minus number of primary cases. So here it will be number of secondary cases are 10 because 10 household members developed. And total number of persons in the group are 25, and number of primary cases are 5. So it will be 10 upon 25 minus 5 into 100. That is 50%. So during an outbreak, epidemiologists are very interested in secondary attack rates because it allows them to probe more deeply into the underlying dynamics of the situation. So it allows epidemiologists to probe more deeply into the underlying dynamics of the situation. Now, it was developed to measure the transmission. Now, it was developed to measure the transmission of an illness in a household, dormitory, or other close aggregates who have had contact with a primary case. It helps to measure transmission of an illness in a household or closed aggregates who had contact with the primary case. It was developed like that, developed with this motive. Now, this parameter is most useful when dealing with infections which are transferable by contact, person to person. Most useful for infections that are transferable by contact. Person to person. It is a measure of contagiousness of an infectious disease. This measure of the contagiousness of a disease. For example, measles had a very high secondary attack rate amongst non-immunized persons, whereas Campylobacter has a zero secondary attack rate as it is not communicable person to person. This question can be broken down to the following. primary cases were 5 people who contracted that virus. They were the primary cases. They returned to the UK, spread it to 10 of their contacts. Those were the secondary cases whom they spread. The total number of people in the households in which they live, or total number of persons in the group in household or contact of primary cases. That is 25. So total number of persons in the group will include primary cases plus secondary cases plus uninfected co-inhabitants. So, like in the question, they say if the total number of all the household members of the 5 passengers is 25, inclusive of the 5 passengers. So, it is including the primary cases. It is also including the secondary cases, that is 10, 5 plus 10, and it is also including those who still have not contracted the infection. Those are like 10 other members. So, this is we can write like primary plus secondary plus uninfected contacts. So this is how we have to calculate, and if it is given in percentage, then always remember to multiply it by 100 and calculate it. And it is now we have to see what is primary attack rate. As well, because we studied about secondary attack rate. Primary attack rate, it is a cruder concept as compared to secondary attack rate, I guess. It is simply the number of individuals that become infected in a population divided by the total population. For example, in that case, it would be 5 by 50 because total members on the board of aircraft were 50. So, number of individuals which become infected in a population divided by the total population will give us primary attack rate. In summary, the attack rate represents the extent of the epidemic, whereas the secondary attack rate represents the infectivity of the cases. So, primary attack rate tells us about the extent of the epidemic, and secondary attack rate tells us about the infectivity of the cases. Now, this question was written in response to COVID-19 pandemic. Okay, so primary attack rate and secondary attack rate. That is what we studied here. Secondary attack rate is equal to total number of secondary cases divided by total number of persons in the group minus number of primary cases. So secondary attack rate allows the epidemiologist to probe more deeply into the underlying dynamics of the situation. It was developed to measure the transmission of an illness in a household or close contacts who have had contact with the primary case. This parameter is most useful when we are dealing with the infections which are transferable by contact, person to person, and it is a measure of the contagiousness of an infectious disease. And secondary attack rate is equal to total number of secondary cases divided by total number of people in the group, that is primary plus secondary plus uninfected minus number of primary cases. So total number of secondary cases divided by total number of people in the group minus total number of primary cases. That is secondary attack rate. Formula of secondary attack rate. If in percentage, we have to multiply by 100. Primary attack rate, it is simply the number of individuals which become infected in a population divided by the total population. So attack rate represents the extent of the epidemic and secondary attack rate represents the infectivity of the cases. Attack rate will tell us about the extent of the epidemic. Yes, primary attack rate, whereas the secondary attack rate will represent the infectivity of the case. Okay, let's move ahead now. A clinical trial is comparing drug A to patients on placebo to prevent MI in patients above age 60 years in a 10-year period. 20 patients needed to be treated with drug A to prevent 1 MI over a 10-year period. 1 out of every 10 patients had nausea as a side effect when taking drug A. What is the number needed to treat for drug A in a 10-year period? Number needed to treat for drug A in a 10-year period is 20, because 20 patients need to be treated with drug A to prevent 1 MI over a 10-year period. So not every epidemiology question needs calculation. Some of them just needs understanding of the terms. So answer here can actually be seen without calculating. The number to treat is the number of patients we need to treat using an intervention to prevent one additional bad outcome. That can be pain, that can be death, that can be disease, MI, intracranial hemorrhage, etc. So 20 patients here needed to be treated using drug A to prevent one MI, one bad outcome. So smaller will be the number to treat, number needed to treat. Smaller will be the number needed to treat, the better would be the drug. For example, if 100 post-op patients had to receive low molecular weight heparin, then the number needed to treat is 100. If 50 and receive low molecular weight to prevent DVT, if it is obvious that low molecular weight heparin, Y is a better drug. Yes, so lower will be the number needed to treat, the better would be the intervention or better would be the drug. Because at lesser number of patients we can prevent a bad outcome. So lower will be the number needed to treat, better would be the drug. Now the formula for number needed to treat is equal to 1 upon absolute risk reduction. Absolute risk reduction, yes. Absolute risk of control minus absolute risk of treatment group. Okay. Let's move further. A study was conducted to evaluate the risk for blindness in a patient with diabetes over a 5-year period. 4 people became blind in Group A, which consists of 100 people. Three people became blind in Group B, which consisted of 100 people. All participants in Group B were given a trial of a new drug, whereas Group A did not receive any treatment. So, given the data above, they are asking which statement is correct. It is about the risk. So, here we have to calculate it seems we should calculate absolute risk first. So, absolute risk will be so now in this risk in this treatment group, all the participants in Group B were given a trial. Group B were given a trial, whereas Group A did not receive any treatment. So Group B, 3 people became blind out of 100. So 3 by 100. So 0.03 was the risk there. And in Group A, it was 4 by 100, that is 0.04. So 0.03 by 0.04. Control is always in the denominator. Just wrote relative risk. If you have to calculate, control is always in the denominator. So it will be 0.03 divided by 0.04, 3 by 4, and so that is 0.75. The risk ratios are an important topic as it is one of the main epidemiologic questions. Now, absolute risk, we can write certain things here. Absolute risk is the risk of developing a disease over a time period. The same absolute risk can be expressed in different ways. For example, if we say you have a 1 in 10 risk of developing certain disease, it can also be said you have 10% risk or 0.1 risk. Depending on whether you use percentage or decimals. Relative risk, percentage or decimals. Relative risk, it is used to compare the risk in two different groups of people. For example, consider the risk of blindness in a patient with diabetes over a 5-year period. If the risk of blindness is 4 in 100, that is 4%. In a group of patients treated conventionally, that is control group, and conventionally means by the standard treatment, and 3 in 100, that is 3%. In patients treated with a new drug, experimental group, then the relative risk is the ratio of these two risks: absolute risk of treatment, absolute risk of control, or treatment or experimental, control or conventional. So risk would be 3 by 4, that is 0.75 or 75% in terms of percentage. Expressed as a relative difference, the new drug reduces the risk for blindness by a quarter. And so the new drug here, in terms of relative risk or expressed as a relative difference, the new drug reduces the risk of blindness by a quarter. A relative risk of less than 1 mean that the event is less likely to occur in the experimental group than in the control group. More than 1 means that event is more likely to occur in the experimental group than in the control group. Okay. Event has less chances to occur in experimental group than in control group. Event has more chances to occur in experimental group than in control group. Relative risk equal to risk of disease in exposed risk of disease in unexposed. In this scenario, it will be risk of blindness in diabetics taking new drug divided by risk of blindness in diabetics with no drug. So exposure can be intervention as well. So this is one formula. So this was it for this session, and I hope it was helpful. It was quite good for me. And take care of yourself. See you next time. Take care.